A very warm welcome to you all. I'm Gill Burgess and I'm here with my lovely friend and colleague Marianne Wood. And together we run a couple of clinics across Croydon and have done for many years. Very old hands at this game. Because the clinics have been so successful, Public Health has asked us, or dragged me at least out of retirement, to do some chatting and look at some opportunities to teach people and show you how successful the clinics are and how we've gone about it. So these sessions have been really valuable and we've enjoyed doing them. For me personally, I've worked, as I say, across Croydon for a long time. My tale began many years ago when I was working in the community, and I was taking care of two young girls in their early 30s with children, and they were both terminally ill with cervical cancer. And it had a profound effect upon me, and it stayed with me a long time. And then later on, I worked on a nurse-led pilot in quite a deprived area, which had lots of single mums and their babies. And for all the work that I could do there was huge difficulties to get these women to have a smear test. It was always a problem. And for the life of me, I didn't really understand what it was. And at the same time, I was working in sexual health clinics. So I heard this word, psychosexual, and decided that I needed to get involved with this to try and understand where these women were coming from and what the problems were. And in those days, the training was open to sexual health consultants and doctors, but certainly not nurses. So I took it upon myself to go to central London every Wednesday night to get some information and listen in, and it completely changed my life for a long time to come. So hopefully today we can encourage you to do some additional training and make some sense of women's health. We have a small agenda which we never seem to stick to. It just comes and goes as it is. We have a little breakout session, and you'll understand why when we actually arrive at that point. So I'll be doing this hour, and then Marianne will come along and show you some wonderful pictures from colposcopy and talk to you a lot about HPV and what you can see in colposcopy and what happens to these women. So I know you'll find it really interesting. So moving on. We have a few facts. We all know that cervical screening is in place to stop women from developing cervical cancer. In the late 80s, the disease was quite profound and many women were dying from it. So the government of the day had to do something about it. And they came around with call and recall, which you're all aware of now. And of course, there's less cancer than ever before. And although 1 in 1,000 women will develop invasive cervical cancer, it's still considerably less than it was. 100 women who have screening, 87 will have a normal result and 13 will be HPV positive. We've come a long way in all of those years. So who attends? Women from 25 to 65 years. The invites remain at 3 yearly intervals, 3 to 5 yearly intervals in England, but in Wales, Scotland, and now in Northern Ireland, it's 5 yearly. And my feelings are that it will change to 5 yearly here at some stage, not too far away. The danger is that a lot of women in the younger age brackets don't attend for smears because they feel that the vaccine is all that they ever need, which of course is not true. And it's been a hugely successful programme. Boys and girls are vaccinated at age 12 to 13, and we've got no problem with that at all now. And cervical cancer, the higher risk is in the 35 to 44 year age groups, but I'm told it can vary year on and year on. So overall, the programme has been tremendously successful. This is a very busy slide about telling you about the pros and cons of HPV. There's a lot going on here. It's a relatively new slide and you can download it on government.com, and I would absolutely recommend that you do. Marianne's going to talk to you a lot about HPV. It's very profound when women get their results, and all of this chart will tell you all about their emotions and physiology and what goes on. It's terrifying for a great many women, but you'll hear much more of that later. But of course, today is all about taking a difficult smear. And as you all know, most women go along to their clinic and they have no problem whatsoever. They take it in their stride. They know the importance of the test. They've had children and babies. They're sexually active. It's not a problem. But this isn't the case for all women. So having had my experience in the community and on my nurse-led pilot, I decided to turn my whole attitude to smear taking round and felt that I could use it as a huge opportunity to get involved closely with women's health. Because I thought, if I can talk about sex and sexual health and the menopause and contraception and endometriosis and all of these things that women have to put up with, it would be an opportunity at the smear to talk about any of their little bits that they may have a problem with. So I went on a mission, as well as the psychosexual counselling, to learn a little bit about everything. And what it was, it gave me the opportunity to recognise if women needed or required psychosexual counselling and why they did, and also take away the fear from women, because as nurses, that's what we do. We take fear out of any situation. But it gave me the confidence to talk about women's health and also allow the patients to recognise that it's not the fearful thing that it's supposed to be. And I was able to acknowledge a lot of their fears as well. So it's all about an opportunity to help women when they've got a problem with a smear, but be able to recognise other problems as well and to talk about them. Many women, as I say, have struggled having the smear. What should be a simple process can be a huge difficulty. But the other thing I've recognised is that it's not always about the patient. I'm fortunate enough to assess many nurses when they've done the training courses for smear taking. And a lot of nurses have a problem themselves with taking it due to embarrassment or whatever. Because when a patient who's anxious walks into your surgery, she only wants to leave and the nurse simply wants to find a cervix. And sometimes this can be a difficult situation. So we just need to think about our own ideas of and processing of actually taking the smear. And do you know, interestingly enough, that over 70% of women who experience sexual violence delay their smears? Well, of course they do. You know, if they've been abused as children or rape has been involved, they wouldn't want to go anywhere near a clinic and have a smear taken. And we know that 1 in 6 women are abused from the age of 16. And the bad news is that sexually abused women, 10% of them do show an increased risk to cervical cancer. And they suffer with acute anxiety and very negative emotions. When I was on my nurse-led pilot, I used to see a huge amount of these women, you know, very thin, very anxious, never knowing where they were going or what they were doing, usually smoking quite heavily, and not knowing where they were coming from. And a lot of it is to do with sexual irritation and violence from their past, and their anxiety levels are sky high. So all of that must be taken into consideration when these women come to see myself or Marianne. Sometimes they could have had a bad experience with the first smear. If the nurse didn't get it right on the first occasion with using the opportunity for educating the patient as to why they were doing it, asking the correct questions. Do you know what we're doing here? finding out what they know, finding out about their information on HPV. They might have had a baby. They might have had a terrible experience having the baby and not really recovered. They might have had other medical procedures, endometriosis, something like that, puts them right off coming in to see you for a smear. So all of these things need to be recognised within your own smear taking practice. Now, I've put a couple of case studies in here. These two ladies, absolutely lovely, were referred to me, and at the end of each one of them, I did a reflection, because actually had the nurse that they went to recognised their problems in the beginning, they probably wouldn't need to have had to come. But Helen is a middle-aged lady and she thoroughly dislikes having the smear test. But her concern was that she had a small hard nodule on her labia. And when she went to see the nurse, she was never asked anything other than the usual first day of the last period and how good or how bad the weather was. There was no other questioning going on. And all Helen wanted to do was for this nurse to have a look at the vagina and have a look to see what was going on. So when she lay down on the couch, she was very upset. And the nurse didn't take any notice. She didn't look at the labia. She looked at nothing. She merely proceeded to put the speculum in. And both the nurse and Helen had a very bad time. And as a consequence, the nurse said, I can't do this, so I'm going to refer you on. So Helen was very upset about this. And quietly, during the course of our conversation, she told me why she'd come to me. And we had a lovely chat. And I talked a little bit about vaginismus and what can happen. And I talked about letting me have a look. And I was definitely going to have a look at the vagina and see what was going on. And eventually she agreed to let me see it. And the first thing to notice was that she was so good at shaving her pubic hair. There was absolutely nothing there. She was as bald as you could be. And of course, we know that if women do all this shaving, it can upset the equilibrium of the pubes. And what she had was a little ingrowing hairnail, and these little hard lumps were appearing. But of course, she can only feel. So she fears the worst on every occasion. So I chatted to her a lot about shaving, because I've read quite a lot of research, and if these women do it continually, it can cause problems. And if they want to shave, that's fine, but don't go so far into the pubic area. You know, leave a little bit there, as it were. So we did the smear. Helen was happy, the result was good, and off she went. And I thought a lot about all of these women that do have the shaving, so worth knowing about that. The second patient was a lovely lady, again called Eileen, 54, happily married or not, certainly not sexually active, been married for 30 years to Les. She's got 3 children, and now they'd all gone off to different parts of the country. She was very sad, Eileen. She was very dishevelled, and she'd been to see the nurse, didn't want the smear, very upset. And I said to her, you know, you're not happy? And she said, no, I'm terrified of the smear, because to be honest with you, Jill, she said, I've got really bad incontinence, and I don't want to lie down on the bed and wee all over it. So I empathized a lot. I said, you know, you're 54. We talked about the menopause, and she'd gone through that, but she'd got this really bad incontinence, which was bothering her no end. But just her appearance was pretty sad. The point I'm trying to make is that I talked to her about the incontinence, but I also talked to her about the menopause and some HRT, because if anybody needed some estrogen, this lady certainly did. So we had a lovely chat about a trial of a bit of HRT. We talked about her sex life. I said, are you sexually active? And she said, no. She said, I lie there at night and Les lies on the other side. We had a really good discussion about Eileen's sex life. We talked a lot about the incontinence and pelvic floor. I put her in the right direction of how to do the exercises, what WhatsApp things she could be using, what apps she could use, I should say. So we had a really good 20-minute session about making her feel better about herself. And that was what was important. So we got onto the couch and there was leakage, undoubtedly, but I reassured her constantly. And when I found the cervix, I said, you know, your little flower is looking at me, all is well. I'm going to take this and then we'll see what the result is. And she got down and gave me a lovely hug and the result was negative and that was fine. And she moved into reception and we made an appointment to see the GP online to get some HRT. And we also talked about breast awareness because, of course, Eileen had not had a mammogram because of COVID and one thing and another. But these are just a couple of examples of what goes wrong in general practice because you're working to a deadline of 10 minutes or 15. But these are women that with a little bit of knowledge, the nurse could help quite a lot. So now what I'd like you to do is just think about how you respond to them and wonder why it would be difficult for the nurse to react. Was the smear just really a task to perform? Is that what we're doing? Are we treating it as a task and not a holistic approach? Are you aware of vaginismus? Do you know what that means? Vulvodynia. Do we know about vulvodynia? Do we know about vaginal pain, of which we are not really sure what causes it? It could be nerve damage, it could be injury. We don't know, but you really ought to know about these little things. Do we lose touch with our professional expertise because we treat the smear as a task? And how can we help these patients help themselves? What, as nurses, do we need to know? There's a lot to be thinking about, but I wonder if we could have a little 10-minute breakout discussion and you can think about the problems that you've faced and come back and tell me all about it and think how we can possibly change it. So I don't know how many there are of you, but Marianne's going to take one little group and the rest can stay with me. I do hope that's all right. So we'll just get it set up now. Okay, thank you. Well, thank you very much for that. It was really interesting. You're obviously all doing very well with the smears anyway. And yeah, time is always of an issue, isn't it? So let's just continue here. In fact, you know, let's talk sex. Scrine in 2001, and this goes back to my psychosexual counselling, and I'm sorry to keep harping on about it, but it's really very important. She says that sex is a psychosomatic activity. It involves the body and the mind. Psychosexual medicine is applied to sexual disorders. It is a specific form of body-mind doctrine when both physical and psychological factors are considered together. So if you get women who are really struggling with the smear, you just need to be thinking what else is going on in their life or what in fact has gone on in their life in the past. And it's all about knowing your own sense of self and being able to feel that you can step into unknown territory to talk about sex and to help educate our patients as well. And taking the smear is the really excellent time to talk to women about any kind of sexual difficulties if she feels that she can raise the subject. Because on a daily basis, you know, we help touch and educate our patients. The smear is a grand opportunity to raise this subject as well as. But of course, unfortunately, as nurses, little attention is paid to this area of our nursing because it's under a climate of everybody demands evidence-based practice. And of course, talking about sex to a patient in the smear scenario can be quite difficult because there isn't a lot of evidence there. But I certainly feel that it's very worthwhile. And of course, if you haven't got the knowledge and you don't know, you've got to recognise in yourself whether or not you'd like to do some training. And that really is important, not only in psychosexual, but in all areas of women's health. The government has just brought out a new women's health strategy, and it's on government.com and well worth looking at. We have great skills, and it's very appropriate to use them in sexual health. So recognise professional boundaries and seek some training, and respond to all these patients when necessary. Now, this is the big one, isn't it? The barriers to avoiding patients' sexual feelings. Well, you know, as somebody said earlier, it's the time pressure all of the time. But the other thing is just not knowing enough about it, feeling uneasy within your own jurisdiction, your own self, the barriers of shyness between the patient and the nurse, and recognising women's loss. If you think back to the case studies I showed you, you know, the loss there of losing 3 children to leaving home, loss of her identity and going through the menopause. These are all really miserable feelings that women live on a daily basis with. And it's, as smear takers, recognising some of that, not knowing the words, not having enough privacy for the patient. And again, you know, not feeling responsible for what we're doing, or indeed the patient not feeling responsible for her own self, and just not knowing. You know, there's a lot of women out there that don't know anything about a great deal. So this is the opportunity for us to talk about all of that kind of thing. But the barriers are there full on. Let's talk about foreplay again. I know I keep going on about it, but it's great in all sexual activity. So why don't we talk about it before taking a smear? And how do we do this without actually touching the patient? Well, we allow them to settle very well into the clinic. We give them a very warm welcome. But most of all, my first question to my patients is always to ask them, do they know why they're having the smear test? Is it a problem for them? Find out how much they know. Do some good history taking. Ask about previous results. I still maintain that the old HMR 101 form, I use that a lot, and I demonstrate their past history. And a lot of women really like to know that. Find out what they know about HPV. I mean, again, so many women do not know about it, and then they get results. And I do a little bit of work for Joe's Cervical Cancer Trust. And a lot of the questions there are, you know, who's he been sleeping with? Where has this virus come from? Talk to them about how low their risk is for cervical cancer. It is indeed low. Talk to them about the HPV vaccination for their children. Establish whether or not they've actually had it. Point them in the right directions. All of these questions can be discussed when they come along. Good communications. You can say, are you sexually active? Can I ask you about your sexual health? What kind of problems do you have? Discover if they've got incontinence. Discover if they're having heavy, hot flushes. All these kind of things, huge opportunities at the smear procedure. Do a good history. Any spot bleeding in between periods, any breakthrough bleeding during or after sex. What's the discharge doing? Do you have any unusual discharge? And of course, a first smear is paramount to asking all of this and all about the screening program. It's really quite profound when you're doing a first smear. Make them laugh. I was just saying earlier on, show them a speculum, show them what you're going to do with it. Tell them how hollow the vagina is. I say it's like an empty toilet roll. You can't do any damage. And I often use pictures, certainly with women who've got learning difficulties. It's essential that you do show them pictures and have the right equipment. Ask them if they need to use the toilet, because a full bladder is not a very good idea. Take your time, listen to responses, and give them lots of privacy, and let them feel that they are in control. It's a sort of very holistic, opportunistic approach all of the time. Because of course, when it goes wrong, it's pretty awful. You've got somebody lying on this bed and there's lots of noises, struggling, anxious noises and movements. And I would say, you know, only ever attempt to put a speculum in twice and just chill. Somebody said earlier that, you know, you can say to them, would you like to insert the speculum? Offer to allow them to take one home to do some practice. Suggest some Vagifem, which is a localized estrogen. I think all women over 50 should be given a prescription immediately. Vagifem is wonderful for lubrication, very easy to use, very easy to take the smear when they have been. Invite them back. Discuss their feelings. How are they? What's going on there? There's absolutely no right or wrong way of doing this, but listen to concerns. And ultimately, if the patient says it's painful, then it definitely is. The barriers can be multiple. The total lack of understanding, domestic violence and rape, a bad first experience at their first smear. We don't know where they've been, where they're coming from. Another thing that's coming to the fore now is unfaithful partners. As one lady said to me, you know, I'm dreading this because my husband's gone off with somebody else and now I don't know where he is and I've got to have a smear and all I can think about is him with another woman. You know, it's pretty awful out there for some people. The cultural barriers are enormous, and I could do a whole session on cultural barriers because there's a huge amount there. Feeling unclean and threatened by all of this, and of course loss, you know, loss, recent bereavements, loss of partners, loss of children. These are all barriers to coming along for a smear. COVID was a major one. So there are a great many barriers to all of it. Psychosexual counselling courses, how does it help? It's experiential learning and a balanced seminar. The programme was devised by Michael Ballant in '69. It's for family planning doctors and GPs, and of course now it's for nurses as well. And on the at the end of here, you'll see where you can have a look online to apply for courses or just get involved with it. But ultimately, it helps you to understand the emotional and sexual world and sexual health of a lot of these patients. It's simply about taking a case study along and you have a really good discussion about it. There isn't, and then there's no easy answer. It's just about gaining some knowledge in your head about how to help these women if they become a problem or they have problems themselves. So I don't really have too many secrets, to be honest. It's just making them feel very comfortable. Observations and looking at body language, open-ended questioning, but most of all, becoming involved in all aspects of women's health. There's a wonderful organisation called the Primary Care Women's Health Forum. It's been running from the north of England for a couple of years. Excellent people, and they do, I think for £48 a year, you get the newsletters and you can go onto their forums and they do wonderful sessions on all aspects of women's health. I can only encourage it, it's brilliant. So lots of reassurance, taking your time. Whether that's us or not. It's gone away. Sorry about the crackling.
Just make sure they're all on mute.
Yeah. Anyway, and the final thing to say is that when you next attend for your own smear, just how comfortable do you feel, and how good is this nurse taking your smear? Just think about it, all of it, and do some reflection when you come away. You can certainly send me emails and talk to me anytime you like if you have any problems with any smear taking. So thank you for that. I just wanted to move on a little bit for a few minutes. I just wanted to mention a little experience I had recently, and it's made me rethink a lot of things. And you might have already done the training for this, but I wanted just to give you a few minutes on the trans man, because it's fairly new into general practice. And as Marianne and I run these clinics for women with big problems, a lot of them anyway, the trans man walked into my clinic, and I can only say I was somewhat alarmed on this occasion. The trans man, of course, as you know, is assigned female at birth. And some of them choose to undergo surgical or hormonal transition, and some of them don't. It alters their appearance in a way that aligns with their gender, or it can alleviate their gender dysphoria, dysphoria being the anxiety of transforming, or just general anxiety anyway. They are assigned female at birth, but if they do change over to male, they're not invited by the national screening programs, and it falls to general practice and gender clinics to actually take care of these people. So there's quite a lot of learning going on there at the moment, and there are helplines and programs being taught. The current cervical screening systems have absolutely no facility to help them. But the guidance for best practice is that every person between 25 and 64 with a cervix is eligible for screening. So it's just something that you just need to be knowing, and you probably do, but anyway. This lady, Carol, is the experience I had a couple of months ago. This person was sat in my waiting room at 5 o'clock in the evening, and it was very quiet, and I went in and saw this immaculately dressed gentleman, booted and suited, white shirt and tie, sitting all alone. And I introduced myself and invited him into the clinic. And we sat down, and I sort of thought, okay, where do we go from here? And I asked him, I said, you've been referred to me? And he said, yeah. He said, my GP wants me to have a smear. He said, but he felt that my practice nurse wouldn't be able to deal with it. So I don't know how you feel about it, but would you be prepared to take a smear? And I said, absolutely. And I had his HMR 101 form on the desk, and he'd not had a smear for 7 years. And prior to that, he'd only ever had 2 smears, and he was 54 years of age. So that was really useful to know that. So the first thing I said to him, and it really broke the ice, was I said, have you been through the menopause? At which point he threw his head back and started to laugh and said, thank you very much for asking me that, because you're the first person ever to do so. So we both sat there giggling, and he said, I have been through the menopause. I get the odd hot sweat, but I don't have any more bleeding, none at all now. But it was a really good icebreaker. I talked to him a lot about HRT and the menopause because I felt I had to discuss it with him. I talked about any other symptoms. He told me he was living with a gay man. There was no children, and they were quite happy together. They weren't very sexually active, but it was not a problem. He didn't want to have any hormones or operations. They were quite happy as they were. He had no difficulties with his bladder. And I asked him if he needed to go to the loo before we sort of attempted it. And he said, no, he didn't. I asked him if he wanted a chaperone, and he said no. So we had a very nice little atmosphere, and everything was moving on perfectly all right. So I said, shall we proceed? And he said yes. And I'd filled out the form. And we went behind the screen. I gave him lots of privacy and lots of time to undress. And my only query really was what size speculum to use, because he was quite a tall chap. Anyway, I used a medium speculum. I went through the procedure. I said, I'm really nosy. I'm going to have a little look, with which he laughed. And he had a full head of pubic hair, which was an absolute bonus because I don't see it too often. And then we proceeded and took the smear. And the really good news was it came back negative and there was no HPV. So all was really well. And it was a really good experience for me to come across this and sort this lovely person out. So patients may request to change gender on the patient record. They do not need to have undergone any gender assignment. And if they do, then their whole record and the NHS number has to be changed. And the appropriate forms and information should be sent out. The barriers, of course, like everything else, access to care, the lack of staff training and understanding in general practice, and gender dysphoria, they have enormous problems one way and another. What you need to know is that not all patients proceed to surgery. You need to create a practice register. And my failing on that day was that to state on the form it was a transgender smear, and I didn't do that because I didn't know. So again, training has had to go on to understand what is necessary. These 2 dates for primary care staff, they've now gone past them, but I would just urge you to have a look to try and find some training for yourself. So thank you again for listening. I hope it's been helpful. You'll have another lovely hour now with Marianne, looking at nice pictures and talking about colposcopy. I have emails, Gill Burgess. You can email me anytime you like. And thank you very much for listening. This is a list of references that you might like to take, but I'm sure that Khadija will let you have them anyway at the end. We're going to have a break now for 10 minutes, a coffee break, for you to absorb all of this, and then we'll come back to listen to colposcopy. Thank you very much. Thank you.
Thank you.
Thank you. Thank you. Thank you.
Pleasure. Khadija. Okay, 10 minutes, Khadija.
Well, welcome back, everybody. I hope you really enjoyed Jill's session this morning. My name's Marianne Wood, and I've been in colposcopy longer, many years than I'd like to remember, really, and done screening in primary care as well before going into the acute setting. The session today is really just a little update on colposcopy. As Gill said before, then we have got some images as well, which are always useful. I'd like to thank my colleagues at St. George's, so that's Yanka and Raj, who helped with the presentation that I've used before. So as Gill said, the screening program was introduced into in the 1980s, and a proper call and recall system, so inviting women eligible, being able to follow up any abnormal results, having a colposcopy service in setting to treat abnormalities, and also a cancer clinic for the well, more rare now, but the cancers that were picked up early on. So the screening program encompasses a lot of people, including yourselves in general practice, who start off the journey for the patient. So before December 2019, before high-risk HPV testing was introduced, we used to send the cells to the laboratory, and they were analysed under the microscope. The image you can see on the left of your screen is a normal result. So the cells on that side have taken up lots of nice pale blue, that's the cytoplasm, and inside the cell is a little tiny black dark nucleus, and that would be a normal cell. It's very small nucleus. On the other side, as you can see and compare, The cell is much smaller. It's got very little cytoplasm, and the nucleus is very large and very dark. And this would be an abnormal cell. Very difficult, really, if you consider how much mucus and material that we would send on the slide. In the old days, we used to use a wooden spatula, and we used to use glass to spread the material on. And then we moved over to the nice thin prep and the nice plastic speculums, which are a whole lot better, and hopefully would have encouraged women to attend their screening. But lots of ladies do go on about the past and how much it's improved over the years. So in December 2019, high-risk HPV testing was introduced. So you'll still be seeing ladies who are on their 3 yearly samples who won't know anything about high-risk HPV testing. Well, possibly. I mean, some ladies do, but actually I find mostly they don't know about the high-risk HPV. It was introduced by the NHS CSP, as I said, in December 29. All women will be high risk, and that's strains or types of HPV, and that's tested using the same vial and the same procedure that we were trained to do our smears on. So the language of the smear result that goes to the house will have changed enormously. So I include a lot of that with my sort of pre-smear talk, because it's the language in the letter that will have changed. So they should get a letter really now saying that high-risk HPV is not detected, or they might get a letter saying high-risk HPV has been detected, and therefore we have looked at the cells. And so this is all different language that you'd need to let your patients know about if they haven't already had a recent sample. Why did we change to HPV primary screening? Because it is the best way to identify women at higher risk of developing cell changes or cervical cancer. It's much more accurate. So the women really like that because it is a better test. It's a red flag, really. So we've got something additional to pick out these women who have the virus, and we can monitor them more closely to see if they do get changes or if they all go back to normal. Screening, probably in some books, it's been quoted as being sort of 60% to 80% reliable, and also has a lot of operator error. HPV primary testing is between 90 and 95% reliable, so it's a really excellent tool to add to the screening program. Gill and I, we were talking earlier, it's the psychological impact of a positive HPV test. There's so much information to take in that very small consultation window. But having worked in colposcopy, and I also work for Joe's Trust on the helpline, it's that shock, that anxiety, distress. They're more concerned about having a virus, to be honest with you, than I think that they are having some abnormal cells. So that you will have heard them in the surgery when you perhaps give your women a courtesy call with any abnormal results. You know, they're concerned about sexual relationships, who's been doing what with who, if anybody has been doing what with who, worrying about disclosure. We get a lot of calls about asking if women, A, can have sex now that they're HPV positive, and if they need to tell their partners as well. A big part is trust and fidelity. You know, they find it really difficult to understand that there's no treatment for it, that they don't need to go to the sexual health clinic, their partners don't need to go to the sexual health clinic, there's no test for the men. Lots of concerns about transmission, immunity. In a way, I'm thankful for COVID because it has elevated the immune system. And when we talk about that now, it seems, you know, it's a very similar sort of subject to compare, because at least they understand that we need an immune system to get rid of these viruses. There is a lot of shame and stigma because women aren't feeling confident to talk to their partners. But I think information is the key. And as we go further, the boys are being vaccinated and they will understand about HPV. And so things will improve as the years go on. every lady I take a smear test in the sort of anxious and nervous smear clinic will get an HPV leaflet, and I do use the Joe's Cervical Cancer Trust ones. I find they're just brilliant. It's got the website on it. It's in a very understandable language. So you can download those and give your ladies to go home with. If a lady's a first smear, then I will print off the sort of cervical screening one, which is also on the website and in a nice A4. So it's really sort of handy to pass on. But again, it explains that language. There's also a contact number. They've got further questions, further information. It's all NHS based information. So sticking to the same information is key. So how do you get HPV? So sex, really. Once is enough, and it includes sex toys. It's usually infecting the skin and the mucous membranes of the genital area. Smoking is really a risk factor because smoking actually affects your immune system. And so I've found that quite an additional benefit to encourage women to give up smoking, is that link with the immune system and fighting viruses off. So that's quite a nice little added sort of extra to help them try and give up. The high-risk HPV strains don't have any symptoms. You'd never see it. You never know when you have it, and therefore you'd never know when it's disappeared. There are hundreds of types of HPV, but women need to know it's only these 14 sort of high-risk strains that we're actually testing for on the sample. As I said before, no treatment for high-risk HPV. And honestly, women do really just stare at me going, you know, what do you mean? There's no treatment. This is ridiculous. I must have some pills or creams or lotions or potions. But no, just good, healthy immune system. Some types of HPV are what we call the low-risk strains, and these can cause the skin warts that we could see and the ones that are visible, so such as warts on your hands or genital warts. These are named of the types or strains of 6 and 11. HPV is transient. 80% of us will have HPV at some point in the screening life. So even women on their first smear, where I've given some information and education about HPV, in that I allude to the fact that they may get a positive HPV at some point during their screening history, and it can come and go. So women could have an HPV positive sample in their 20s and then have it again in their 40s, or etc., because that virus can come back because of the immune system. These are the high-risk types that we test for, and the most common that you're aware of because of the vaccines are the type 16 and 18. These cause most cancers, hence these were the types that were put into the vaccine. 99% of cervical cancers do have high-risk HPV in the etiology. So we'll just do a little reminder about taking smears. It's very easy to think, because we've got this virus test, do we still need to be really careful with taking our sample? And yes, we do. We do need to still take those cells, because if the test shows that high-risk HPV has been detected, then these cells are really important for the laboratory to look down the microscope. So this is the squamocolumnar junction, just a reminder. It's that line between the pink squamous epithelium that we see on the outside of the cervix, and that joins to the redder sort of glandular tissue that lines the cervical canal, that produces your normal mucus and discharge, or as I say to some women, it's your sort of internal shower. It helps to get rid of all that vaginal with the cells, and all that discharge is mostly normal. We need to sample the transformation zone. That's the area of the glandy tissue that's been exposed to the outside of the cervix, that changes into the nice, it transforms into the squamous epithelium. And that's where you will get the HPV causing most of its trouble, because areas of change are a problem. So dyskaryosis, and therefore CIN, occurs within the transformation zone. So if all cervixes look like that, we have a fantastic job. This is a cervix very beautifully marking out your squamocolumnar junction. You've got a lovely line that separates those two types of cells. You've got the squamous on the outside, and you've got that nice frilly grape-like glandular tissue in the center of the cervix, which looks a little bit red when you are taking a smear test. So the results that your lady might receive, hopefully it's the top one. High risk HPV test is not detective. That's your negative sample, your negative result. So as Gill alluded to earlier, England, we're 3 yearly at the moment, between 25 to 50 and 5 yearly over 50. Scotland and Wales are at 5 years, but I too agree with Gill that very soon I'm sure we will all go to 5-year recall. HPV, you may get a result that shows you're HPV positive. If you're HPV high risk positive, then the laboratory will look at those cells down the microscope, and they will then say whether those cells are normal or abnormal. If the cells are normal, which is again very, very common, you'll repeat the high-risk HPV test with you in primary care within a year. And I've put in red there, and unless this sample is the first post-treatment sample, in which case this lady, if she was HPV positive, should be directly referred back to colposcopy. The other result that the lady might receive is high-risk HPV positive with low-grade abnormalities. These are your borderline or mild dyskaryosis, and these ladies will be directly referred for colposcopy for a 6-week routine appointment. The other group will be high-risk HPV positive but high-grade cytology, so those cells quite abnormal, moderate, severe, invasive, query glandular, and these ladies will be sent for a 2-week appointment in the colposcopy clinic. So it's very fast, and I know we were always very reluctant to have women on a 2-week pathway because that kind of meant cancer, and we were trying to get cancer away from screening. But anyway, psychologically, a 2-week appointment probably is very good for our ladies. The other result they might receive, of course, is an inadequate result. And these ladies will repeat in 3 months. That could be inadequate for the high-risk HPV test itself, or it could be that you've got an high-risk HPV positive, but they couldn't look at the cells to see if they were normal or abnormal. And these are really about 2% of women, but of course causes a lot of anxiety. There's a result there at the bottom, which in fact, I think I've made a spelling mistake. So it's high-risk HPV positive. And when they look in the borderline, these are borderline abnormalities on the glandular tissue. So it's the CGINs, the glandular abnormalities. You don't see this result very often. Don't confuse it with borderline squamous. It's borderline glandular, and I've missed out the word glandular, so apologies for that. And again, this result will have a 2-week appointment. This is the algorithm we were all used to when high-risk HPV was introduced. As I was in the colposcopy world at that time, I loved the fact it said colposcopy referral in pink, and colposcopy referral. And then after that, it was like, now what do we do? Because of course, we're going to be seeing lots of women who are high-risk HPV positive, but may have had those 3 samples where the cells are normal. And that was a very difficult one for us because we didn't really actually know what to do with ladies who was just kind of normal but had a virus. So this was a bit tricky, but it's quite easy for the primary care protocol. So in primary care, of course, now very much more recently, perhaps than in the past, the guidance kind of changed a little bit in that first 6 months sample should be taken in primary care. Having been in colposcopy, we kept ladies for that 6 months, especially at St George's, but we were reminded about the pathway, and so I think most of the hospitals will now discharge for that 6 months post-treatment sample after treatment. So that's a really good opportunity to ask women, you know, how was their colposcopy experience? Are there any period problems post the treatment? Just keeping an eye on things, having a look at that cervix to see if it looks nice and healed and pink and smooth. But a really nice opportunity to have a chat about colposcopy. Of course, the lady should get referred back if she does have high risk HPV positive, even if the cells are normal. So that's the only sort of different sample. If she was high risk HPV negative, which most ladies are, but not all, they will return to the routine recall 3 yearly. So we talked a little bit about vaccine, and I love vaccine as well, because many of the women I see have got young children, and I also tag that leaflet into my other leaflet, because if the children are little, then I say, oh, they'll grow up and they'll have the vaccine for all this, which would be brilliant. And obviously, if they've got teenage children, then it's a lovely introduction just to remind them to, you know, say yes when the kids are getting their vaccines, so to help try and prevent this, you know, in years to come. I think initially the vaccine was, I think, Cervarix, which was just type 16 and 18, and then it changed to Gardasil, which introduced the wart virus types. So it had a sort of double-edged sword, which was, I think, handy for the sexual health clinic because it's helped reduce the incidence of genital warts, as well as cancer virus. And then, as you heard, Gardasil 9, that includes 7 high-risk strains and the 2 low-risk HPV strains. And a very successful program, but again, lots of questions because women who have had the vaccine, young women now, and they have an abnormal smear, they're quite shocked about that. How can I be HPV positive? I had the vaccine. And the answer to that is really that, yes, the vaccine it's protected you from 2 of the strains, but there are 12 others that you may have come into contact with. And also we don't know about how people's immune system reacts to a vaccine. So some of us have very good response and some of us don't have a very good response. And we don't really know how long the vaccine will last for either. So these are some of the questions that we get asked in the clinic. Some pictures of the vaccine. It could be that they actually changed boxes over the years. This slide has been up. So how do we reduce the risk of HPV? So the immune system really is key. It will clear the virus in most people, but you might find that women who have other autoimmune conditions, such as multiple sclerosis or rheumatoid arthritis, these are the ladies that may continue to have a positive HPV test for a little bit longer. They still have the same referral, but even in colposcopy, we'd keep an eye on them. And we discuss with them that they may be positive a bit longer than other people, and we wouldn't be keen to treat women just because of persistent high risk HPV. So as long as the cells are low grade, we would continue to monitor. So as I said before, not smoking. People do talk about condom use being like that's the answer, but it isn't. It is very good for other sexually transmitted diseases, but it's not 100%. There's a lot of genital skin-to-skin contact before we have penetration. It goes with the territory. Probably more recently, there's been a bit more discussion about using vaccination as a possible treatment for CIN. There are some studies going on at the moment to see if it kind of might offer some cross protection or boost immunity, but maybe look out for that in the future. And again, these websites, the NHS CSP, Joe's Cervical Cancer Trust, got lots of information that's in a really understandable way on the website. So do use it. at the time of screening, it's important just to stress to the ladies that should they get an abnormal smear test, they will be directly referred to their local colposcopy clinic. And I say that it is their local unit. So it could be that you know that this certain lady wouldn't want to go to that hospital, and so you do, or your surgery have the right to do a written referral perhaps to a neighbouring hospital if you feel that that lady would prefer to go there, but that one would require a written referral. But normally it's you go to the local clinic. It cuts out perhaps your referral work that you might have had to do in the past, but it does mean that they often get their appointments through very quickly, and occasionally they're getting the colposcopy appointment through the door before the result of the smear test, and possibly before perhaps even you've had a time to give them a call and just chat to them about it. And I do think that that's key. Just having that joined up approach and care for women who say, oh, I took your smear test, I've just seen your result is a little bit abnormal. Have you got any questions? Can I help a little bit more? So it's quite nice. This is also the opportunity to inform the colposcopy clinic about maybe special needs for that particular patient, any physical, psychological, interpreting needs. These are all really good things to let your colposcopy coordinator know about. The only information we get in colposcopy is literally that smear form. We don't have any other information, so anything like that is really useful. So please do contact them. So what happens when they arrive in colposcopy? They would have been sent an appointment, and in that is a nice up-to-date leaflet about what might happen to them. Really, it's a bigger sort of magnified check of the cervix and the lower genital tract to identify, diagnose, monitor and treat precancerous lesions of the cervix, the vagina and the vulva. I'm just looking at my screen and I've got a message, so 1 second, I'll be back to do the talk. I think I'll click, it's got a reboot, so I'll do a remind me in a little while. Is that all right?
Working?
Yeah, apologies for that. So this is the colposcopy room. Lots of equipment in there. I mean, that's mainly for the photograph, to be honest with you, but hopefully it's not quite as crowded as that. You might see on the left-hand side, there's a monitor there. Most units now, that's part of our quality assurance, is that we have monitoring for patients to watch the examination. Should they so wish, they may tell you that we made them, but we honestly don't make them. We offer them for them to see their examination, but we really don't make them see it at all. So they're a little bit curious because not many women have seen a cervix, and maybe that would be their only time to see it. So it's very useful for them to see that as regards to childbirth and seeing that their baby come through that little hole in the cervix. So it's quite a nice sort of education tool. Maybe not for treatment. I don't think many women watch it so much while they're having local anaesthetic or LETS treatment. So we do lots of talking as well. Luckily at St George's we have a half-an-hour appointment. Much of that is spent with explanation and gaining consent. We position the lady comfortably with the legs supported, which is quite a nice way for them to be able to relax a little bit more on those stirrups. We insert the speculum, the correct size, and we listen very intently to smear history. We would take that and ask women how their experience has been with screening so that we can use the correct speculum. And then we apply the solutions just with cotton wool, and then we would take images for their records, so that way you could see things are progressing. And actually that's when women perhaps like to see the screen. They can actually see the abnormality, they can see how big or small it is, and perhaps it puts it in proportion for them. And they can see that there's often no lumps or bumps or anything. The cervix is smooth and pink, and these are microscopic changes. So as a colposcopist, we would then make a colposcopic impression of the area, which could be low grade, where we just monitor and would eventually perhaps take a biopsy just to confirm that everything is, that the area doesn't need any treatment. But for the higher grade areas, then we would offer the LETS treatment. A lot of colposcopy units do offer what we would call a select and treat service, so that the women could have that LETS treatment on their first visit, if they were happy to. And not everybody is, certainly, you know, people have got things to do, children to pick up, interviews to go to, and so, you know, it's purely there. It would just save perhaps another appointment. So many women do take up that treatment at the first visit, as long as they've been prepared and they know what to expect. So the acetic acid we use binds with the higher amounts of protein. So in that normal cell that we saw at the beginning, you could see the nucleus that's really the protein part is very, very small. Wouldn't take up much of the aceto white, but that big cell with that huge nucleus and lots of protein will shine up bright white for us. Iodine works the other way, and good healthy tissue will go dark brown, and it will highlight the abnormal area because that wouldn't take up the iodine. And so you can see that on the colposcopy images. So this is a lady who might attend your surgery for her smear test. Cervix is pink and smooth. You can see the squamous epithelium around the outside, and you can see a central area of glandular tissue. And be careful of saying to the lady that looks healthy, because you're not too sure at this point, but it does look smooth and pink, which is what I tend to say to ladies. Because this was an abnormal smear, and this lady was referred to colposcopy, and you might see that white area showing out nice and bright. So that's an abnormality. So we have to be careful of using the words healthy. For the cytology versus sort of biopsy, your low-grade abnormalities would equate to viral changes or CIN1, and your more higher grade areas would equate to CIN2 or 3. You can see the little black lines in between, because 30% of low grades referred to us would actually turn out to be high grade, and vice versa, although there is more accuracy the higher level of dyskaryosis that we see on cytology. So some women may be referred for treatment, but when we look at them, the area doesn't seem as bad, and therefore we would take a biopsy and we would offer monitoring. Vice versa, we could see an area with low-grade abnormality, but the biopsy actually comes back a little bit higher grade, and that is really disconcerting for women. They don't like it when things don't add up. We like everything to be like in the books, so uncertainty is difficult to manage. So CIN stands for cervical intraepithelial neoplasia. It's a big mouthful. It sounds like cancer to me, but it isn't. And it's CIN. It's what we call pre-cancer changes. There's the other CGIN, which you may have come across in the practice. This is cervical glandular epithelial neoplasia, CGIN. 80% of abnormalities are squamous, about 20% would be glandular or smile. That's another term that we can use. So CIN is really abnormality on the squamous epithelium, and if was progressing over 9–10 years, could turn into a squamous carcinoma. The CGIN is abnormality on that glandular skin. So that skin that's hidden within the cervical canal, a bit more worrying because access is more difficult and you can't see it so well. And these are the ones that turn into your adenocarcinoma. So the two different cancers that the screening program helped to detect. Yeah. CIN1, if you looked at a piece of cervical biopsy, that's a picture of the stroma of the skin. For the mild one on the left-hand side, so the low-grade change, you can see, to be honest with you, most of it is completely normal, other than a little bit of sort of higher colour at the bottom third. And that's what the laboratory would call CIN1, if you compare that to the picture on the right-hand side, where that colour is full thickness, it reaches nearly right to the top, and those cells shedding off are high-grade cells. You might see some little white halos. That's the effect of high-risk HPV within the stroma. So what do we do with CIN1? These are the low-grade changes, and we know that these resolve the majority of the time. We monitor with regular colposcopy, cytology, and histology, so taking biopsies and repeat screening. Nowadays, the pathways have changed. From colposcopy, where we used to keep ladies on monitoring, we actually refer back for screening now. So it seems to be that primary care, your role is screening, you know, big time. And very little cytology is actually done within the colposcopy clinic these days. You would repeat the smear. If the smear is again abnormal, she would be directly referred back. It seems a bit bouncy to me, and we had real trouble in colposcopy thinking, no, that's such not a good idea. Why don't we just keep everybody? But obviously resources don't allow for that. Again, it's a hard message. The immune system is all that is required. So this is what some very minor changes might look like on the cervix after we've done our colposcopic, put our solutions on. The picture on the left-hand side, you might just be able to see very, very faint, sort of white, lacy, sort of like a net curtain around the sort of 12 o'clock to 3 o'clock position of that little os that you can see in the middle. So that would say to me that that's a very minor area of change. Some ladies, of course, will have HPV effect and mild changes to the vagina. And also we see it on the vulva as well. So again, some low-grade changes. That's the cervix in the middle with some mucus coming out of the cervical os. Centrally, you've got the glandular tissue, which is a little bit red and a little bit bleeding because we've touched it. But you may see 11, 12 o'clock if you look closely, and also sort of 1 o'clock. There's a little white area just starting to show itself, and these are representative of very minor change. So what do we know about CIN2 and 3, the higher grade changes? So these are more likely to persist, and left untreated have a 50% chance of turning into cancer within 8 years, which also means that 50% don't, and that's a really difficult category because we're making decisions for women and offering them treatment. You may have come across some women who actually have said, no, I don't want treatment just yet. I want to wait a little while. And these ladies will be monitored in the colposcopy clinic. But it is there for discussion. And the jury is out now a little bit more to conserve women with a moderate abnormality that perhaps don't need to rush into treatment. As I said, we offer treatment probably for the CIN3s, definitely. And that's usually with a large loop excision of the transformation zone, which is a little hot wire. It's not necessarily large. We would use the size of loop to match the abnormality, and always taking the least amount of tissue as we can. So going back to those other pictures, comparing it with this one, you can see there's the cervix with the pink skin, the squamous skin all the way around the outside. The os is in the middle. But putting the acetic acid on has shown this area of bright white abnormal epithelium, and just the fact that it's very white and it's jumping out at us indicates that that's high grade change. Women would be given or offered a LETS treatment, sometimes a cone biopsy, but that's usually probably given for ladies with the glandular change. If women have completed their family or have persistent abnormalities, high grade, they may be offered a hysterectomy if actually the very small cancers are actually found. But there's a new surgery called a trachelectomy. I say new, fairly new, which is offered to women with the very small stage 1A, 1A2 cervical cancers. And this is a child fertility sparing treatment, and many babies have been born for women who would otherwise have had to have had a hysterectomy. So that's absolutely fantastic. There are some other non-excisional treatments you may have heard women talk about. Cold coagulation is actually heat, electrical diathermy to burn away the tissue. Laser we used to use incredibly a long time ago, but women always say, oh, I've had some laser treatment, but probably they didn't, but anyway. And cryotherapy is freezing. That's just to destroy the tissue. That tissue wouldn't go to the laboratory, so it's always important to have biopsied those areas before you offer treatment. So this is a nice normal cervix after treatment. So again, after treatment, we hope that women look exactly the same as they did before, but there is evidence of treatment. I don't tend to use the word scar of treatment because if for women that sounds kind of a horrible word, so I tend to say I can see there's evidence that you've had treatment. So the cervix can be a little bit changed. But again, you can see the squamocolumnar junction, squamous epithelium around the outside, and the redder glandular tissue in the middle. Side effects of treatment: 4 to 6 weeks of bleeding and discharge, no swimming, penetrative sex, or nothing up inside, basically, because you may introduce extra bugs. No travel abroad, only because they could have a hemorrhage or an infection that needed medical intervention, but also you have to tell your insurance company, and that's probably the biggest part of it. But if they told their insurance company, it should be fine. So other than the risks, hemorrhage, infection, and by hemorrhage we mean soaking pads every hour, going to A&E. Infection, we mean a really bad, offensive, smelly discharge. They will get a yellowy kind of watery discharge, but as long as they're not feeling unwell or it's not very, very smelly, then we would leave well alone. There's a chance we don't remove all of the abnormality. Obviously, that abnormality that you saw on that picture, you don't know how far down it goes or how far wide it spreads. So we're trained to make a really good judgment for treatment, but there could be a chance that we kind of look at the face of the clock, but we may not be able to see the batteries, is how I kind of explain it to women. After treatment, we can make that little hole that we've all got in our cervixes, we can make that much narrower. That doesn't make sense, but narrow, and that can cause some period problems. So prolonged periods, perhaps painful periods, brownish discharge periods that last for ages. So look out for that when you take your history at the post-treatment. Any problems with the cervix after treatment that you're not happy about, then of course refer back. And there's a 1% increased risk of premature labour, so a baby coming a little bit early. Women who are pregnant should attend colposcopy as per the criteria. We welcome women in pregnancy. It is safe, it's reassuring, and it does not cause miscarriage or premature birth. It doesn't make abnormalities worse, which is what we used to think in the past. And so you may hear contradictory information. I'd hear women saying, my midwife said I mustn't come, and all this sort of stuff, but we would encourage all women to attend. So some little colposcopy pictures at the end, which we promised. We've had maybe a spot of lunch, who knows, but anyway, here we go. So ectropion, so that's describing that exposed glandular tissue that we've been seeing throughout this presentation. Doesn't need any treatment. It could cause some bleeding after sex, of which women could have some treatment for, such as silver nitrate, or even buying the products over the chemist, from the chemist, these acidic gels that help to epithelialize the cervix. Once that glandular tissue is exposed to the acids of the vagina, it will turn itself into that squamous epithelium, which is what you want to happen. Atrophy and atrophic cervix, you might get these little petechial hemorrhages when you take your smear just with a little bit of pressure. The squamocolumnar junction starts to recede within the endocervical canal, can make it quite difficult to take a sample. So sometimes these women are given a few months of estrogen cream to help epithelialize the cervix and to help you get some extra cells. For this lady, probably use an endocervical brush as well as the cervix brush to get an adequate sample. You might have seen trichomonas, this sort of spotty kind of discharge and this spotty cervix. If we put iodine on, it shows up equally like what we call a leopard pattern. And so that's very classic for trichomonas. Genital warts, these are the low risk HPV that we've seen probably very regularly in your smear taking or in the colposcopy clinic. Sometimes they can be really, really big. And I have known them to be excised, and you may see them on the cervix. The woman wouldn't know unless she has felt inside sometimes. So they can be different shapes. You can have clusters. They can be really quite uncomfortable, but sexual health clinic is where they would need to be referred. This is a picture of a wart on a biopsy, and you can see that sort of frondy, sort of coral effect of the blood vessels, very classic on a biopsy. Candida and thrush, I have a story about this because this is incredibly sore, and hopefully you don't see many of these women. I don't know if they'd be able to manage a speculum, to be honest with you. But I had a lady once in colposcopy who she was in her 60s, and I was doing her follow-up smear. And when I looked at her vulval area, it was kind of just of one. There wasn't any definition of the labia major or minor. It was just one sort of mound with a sort of little slit in the middle. And I just thought, gosh, that looks so different to what I'm used to. Didn't quite know what it was. But I remember asking her, I said, I hope you don't mind me saying, but your vulva doesn't kind of look like what I'm used to. Have you got any history of anything? And she said, oh gosh, she said, I'm so glad you've asked me. She said, I've been itching there for years and years and years. I've been treated for thrush 100 million times by the GP and pharmacy, but nothing better. And so this woman just had classic lichen sclerosis, and the skin can fuse and become very different, but they usually get kind of itching, night itching. So be wary of your lady who's recurrent sort of thrush treatment. And actually there's a very good treatment for lichen sclerosis. It's usually steroid treatment and maybe some estrogen, but there are also vulval clinics to refer these ladies to control their symptoms. So she was actually delighted, and it was a big learning curve for me to bring it to people's attention. So that's another thing that we need to be aware of, some of these vulval conditions. Cervical polyp, you may have seen some of these when you've taken your smears. It's always a bit shocking when you put your speculum in, you open it up and there's a sort of thing looking at you and you're like, oh God. So you can take the smear first if you feel confident that the brush will go 360 5 times. Sometimes the polyps can bleed, they can grow, they can, get worse. So we do refer to have the polyps removed. This is another picture of different kind of looking ones. So that one on the left is probably like a fibroid epithelial polyp, little soft one on the right hand side, and then this very long dangly one at the bottom. And of course, many women with cervical polyps may have polyps in their wombs as well, and they can cause menopausal bleeding or postcoital bleeding or intermenstrual bleeding, I guess, as well. So sometimes it's better to get them referred, and then you know that these ladies are sorted out. Nabothian follicles, very common. You might see these when you're taking smears. They're usually yellowy balls of they're blocked glands, basically. It means that you've had some columnar glandy skin outside on the cervix that's got covered up with that squamous skin, and then some mucus has got trapped underneath. They usually disperse on their own. If you're confident that that's what it is, then that's good. If you're not feeling happy, then please refer. We love referrals for Nabothian follicles, because sometimes we do pop them and remove them, but they are self-limiting, they will disappear. But sometimes women say that they've, examined themselves and they can feel these lumps on their cervix. That's another follicle. You can see that down at sort of 5, 6 o'clock. That sort of quite swollen, tense area. You can almost see the mucus behind. But again, very normal. Doesn't mean you're going to get any abnormalities or cancer in the future. When we put our colours on, and that you saw that white area earlier of these high grade changes, this is what we look at through the microscope, and we can see these patterns. We'd call that mosaicism or punctation. You can see the little heads of the blood vessels, and you can see the patterns starting to change within that area. So high grade, offer treatment, cancer may not be very far away. And again, here's a little area. You can have a very small area of very high grade change. Aceto-white area with some patterns of vascular change. Again, lots of very thick white. You can see the vascular patterns, the blood vessels, the pollarded vessels. These are all indicating high-grade change, or even the beginnings of a cervical cancer, microinvasive disease. And if you did the treatment, hopefully that's all she would need doing. So really fairly straightforward and easy to manage. So this is a cervix you might see. Again, it looks smooth, it would look pink, but a big area of change, centrally very high grade, a little bit more mild around the outside. You can see that pale white around the outside, but quite fragile and thick and white and friable in the middle there. Again, just on cancer, okay. And this was a kind of 1B, I think. This lady had a more advanced cancer. You can see it's quite well defined. It's raised. It doesn't look like any other of the skin of the cervix. It's quite different, very fragile, thick white, and very friable. Not such a good picture, but again, high grade changes in the center of the cervix there. And this is what we're really all trying hard to avoid. So ladies getting cervical cancer. So this necrotic, it's not smooth, it's got lots of ridges, it would probably bleed to the touch, maybe have an odor. And of course, you'd refer straight away for that. You wouldn't worry to do a smear, just an urgent referral. So let's hope we don't get ladies to this point. Everything is helping us to avoid these situations. So again, NHS-CSP, there's a document number 25 with lots of pictures in. That's quite a good one. Publication number 20 for NHS-CSP, that's colposcopy and program management. And again, good old Joe's Cervical Cancer Trust. And that's my email. Again, if you've got any questions, both Gill and I are very happy to answer them. So thank you very much for listening. I think we've got maybe a couple of minutes for a couple of questions, if anybody has any. Do you want to come in, Jill? I'm bringing Jill in as well. Anybody got any questions before we close?
I was going to ask a quick question. How about if you have in cervix so really difficult to insert the brush into, or the brush into, and it appears if they're impenetrable? What do you do?
Honestly, if I can't take a proper smear, so the cervix is stenosed and that brush won't go in, then I would refer, because you're just not being able to adequately sample the canal. So unfortunately, that one is a referral.
Oh, okay.
Yeah.
No, and they used to supply both, I think, the brush and the broom, but they only supply Only give us the I think the brush, it's called a brush. I'm mixing them up.
Oh, sorry. The cervix brush, so CERVEX is the green one.
Yeah.
That some of the little filaments would introduce into the canal, hopefully.
Yeah.
There's also an endo-cervical brush. You can buy them through your primary care magazine, you know, your ordering system.
Right.
Yeah, they are very useful to have because they just seem to go that extra little bit for those ladies who need that extra bit of a sample. Because your aim is to sample correctly, however that may be, you know, with whatever tools you have. If you can't sample correctly, then refer, but then just have some endo-cervical brushes. Do you agree?
Yeah. The thing about that white brush is that you don't bash it like you do the green one. You just sort of walk it around the inside of the pot because the brush is that little bit heavier, isn't it?
Yes.
So if you bash, you'll just squash all the cells up.
So you can use the little green one to sort of stroke the endo-cervical brush. Yeah. So that's what I do.
And always do that first, don't you? Always use the green brush first.
Yes.
Green first. Yeah. And then the white one just quietly round, but then just go around inside the pot. But certainly in older women, it's very useful.
Yeah. Well, what I was saying is they don't supply us with the white ones anymore. They only send the green one, the green. The green with the green.
Yeah. Well, whoever does the ordering in your surgery, just tell them that you want some of the cervix brushes.
Right, okay.
And they have to buy them. I forgot the name of the company now, but you know the big catalogue that you have, wherever they buy the speculums from the catalogue, they're absolutely there. Yeah.
Well, I'm not in work next Thursday, but I know I've got a big load of packets there. So if you email me, then I can send you the name of the whatever it is, the manufacturer is what I'm trying to say.
Yeah. Okay. All right. Thank you. Thanks.
Okay. Pleasure.
All right. That the lot.
Anybody else?
No. Thanks for coming anyway. Nice to see you all. Happy smear taking.
Thank you so much. Thank you. Thanks.
Thank you. Thanks, Ella. Thanks again.
Bye-bye.
Bye-bye. Bye.
Mute.